Good morning, dear colleagues. This is Dr. Walid Al-Basuni, Assistant Professor of Obstetrics and Gynecology at Shams University. Today we are going to discuss an important issue that unfortunately still affects a group of our patients that could have been saved the detrimental drawbacks of this topic if they have been properly managed, which is RH isoimmunization. At the end of this lecture, all of you should be able to define RH isoimmunization, explain the pathogenesis and etiology of RH isoimmunization, identify the various clinical types of this condition, put a plan of management for a case of RH isoimmunization, outline the postnatal diagnosis and management of a hemolytic disease of the newborn, appreciate other types of red blood cell antibody alloimmunization, appreciate the difference between immune and non-immune hydrops. What's our definition? The formation of maternal antibodies is called isoimmunization. It can lead to various degrees of transplacental passage of these antibodies into the fetal circulation, causing an antibody response sufficient to destroy the fetal red blood cells. When any fetal blood group factor inherited from the mother that is not possessed by the mother, antepartum or fetal maternal bleeding may stimulate an immune reaction in the mother. Maternal immune reactions also can occur from blood product transfusions. This is a simplified figure of the red blood cell. The actual representation of the antigens is much more complicated. Simply, the blood group is identified by the presence of the antigens, whether it's A, B, AB, or O if no antigen is present on top of it. And the RH, the simplified form, it's just the D antigen. And we're going to explain later on what are the various forms of the antigens that could be present. The binding of maternal antibodies to fetal red blood cell antigens leads to hemolytic disease in the fetus or the newborn, characterized by hemolysis, bilirubin release, and anemia. According to the severity of the hemolysis, the clinical picture varies from just mild jaundice up to severe fetal hydrops and, unfortunately, intrauterine fetal death. The severity of the illness encountered by the fetus may be detrimented by a number of factors, including the degree of the immune response elicited, how much antibody is produced, how strongly the antibody binds the antigen, the gestational age at which the diagnosis is made, and the ability of the fetus to replenish the destroyed red cells to maintain a hematocrit sufficient for growth and development. So, what is the RH system? It's actually a complex of 5 antigens, including the C, D, and E antigens. These antigens are inherited together in a distinctive pattern, reflecting the underlying genotypic makeup of the parents. There is a C capital and C small, which are alternate forms of the same antigen, E capital and E small, which are also alternate forms of the same antigen, but there is only one D antigen that is either present or absent. Patients with the D antigen are termed RH positive, and those lacking this gene and hence the antigen are called RH negative. The RH negative is approximately 50% of the whites, 5% of the African Americans, and only 1 to 2% of the Asians and Native Americans of the population. This is a very nice graph that just tells us that the immunization is not just the D antigen. There are other forms of antigens that could cause an immunization. Let's see, for example, we have a Lewis antigen, Kell antigen, other non-DRH antigen, as we said, that the E capital, E small, C capital, and C small, Duffy, KID, MNS, Lutheran, and P antigens. And much of them are involved in the hemolytic disease severity. So some of them have a mild to severe form of hemolysis, like the non-DRH antigen and the Duff and the KID antigens, and others are not associated at all, like the Lewis and the I antigen. We're going to have a detailed talk about this graph or this figure in the face-to-face presentation. So what's the effect of antibody development on the fetus and the newborn? One study indicates that 17% of RH negative women, RHD negative women, who do not receive an anti-D immune globulin prophylaxis during pregnancy will become isoimmunized. Let's think about this. Why only 17%? Think about it and let's negotiate it in the face-to-face presentation. The first immunoglobulin Ig type produced is the IgM isoform, which does not cross the placenta to any extent. In a subsequent pregnancy, passage of minute amounts of fetal blood across the placenta into the maternal circulation, a relatively common occurrence, can lead to an amnestic response of maternal antibody production, which gives a robust and rapid then initial response. The chance of a significant fetal or newborn disease in a woman's first at-risk pregnancy is therefore low. It's however important to consider prior pregnancy losses or terminations as potential exposures because they could influence the risk of fetal or newborn disease. Secondary antibody response is characterized by the production of IgG antibodies that could freely cross the placenta and enter the fetal circulation and bind to antigenic sites on the fetal red cells. The red blood cells that are highly bound to the antibody then are hemolyzed in the fetal reticular endothelial system and are destroyed later on by the complement-mediated pathways. The hemolysis releases bilirubin, and the fetus excretes the bilirubin and its breakdown products in the urine. If the fetus is able to augment this erythropoiesis to keep pace with the rate of the hemolysis, serious anemia may not develop. However, if large amounts of antibody cross the placenta, resulting in destruction of large numbers of fetal RBCs, the fetus may be unable to sufficiently replenish the RBCs, and anemia may ensue later on. When fetal anemia is significant, fetal hematopoiesis increase, including the recruitment of alternative sites for RBCs production. The fetal liver is an important site of extramedullary hematopoiesis. When the liver produces the red blood cells, the production of other proteins decrease, resulting in a lower oncotic pressure within the fetal vasculature. This consequences in conjugation with the increase in intravascular resistance to flow caused by islands of hematopoietic cells in the liver can lead to the development of ascites, subcutaneous edema, or pleural effusion, which are the items of hydrops fetalis. Severe anemia could affect the fetal cardiac function in two ways. First, the anemia can lead to a high output cardiac failure, as the cardiac system attempts unsuccessfully to keep pace with the oxygen delivery demands. The myocardium becomes dysfunctional, resulting in effusions, edema, and ascites. Second, the anemia itself can cause myocardial ischemia, and hence compromising the myocardial function. This combination of fluid accumulation in at least two extravascular compartments, this is, as we said, is called hydrops fetalis. This is the chances that a fetus will be Rh negative. If the mother is Rh negative, which is an absent D, as we said, just we give her here a picture of a small d, but they're actually absent D, and the father is Rh positive, so he has the D. What's important is the father could be homozygous or heterozygous. So if he is homozygous, he has both genes present, so he has both D genes present on his part, and if he's heterozygous, he just has one gene of the D present on his side. So according to the Mendelssohn rule for inheritance, the ratio of offsprings to be Rh negative ranges from 0% up to 50%. This is the clinical picture. So what's the problem with babies whose mother are Rh negative and sensitized? As we said, the antibodies cross the placenta and they start attacking the baby, and they start the process of hemolysis, and they start the process of heart failure, and hence the babies will start suffering edema. First of all, the picture on the left, we have what's called polyhydramnios. What's polyhydramnios? This is an increase in the amount of the amniotic fluid, which is because of a part of the failure or the heart failure that the baby is suffering. On the other side, we see a picture of scalp edema, and this is another picture of edema that may be generalized all over the baby. This is ascites and pericardial effusion and skin edema, which could also affect the baby in the later forms. So actually, if the mother is sensitized, she may not complain of anything as the mother herself, but the problem will be in the babies. So the babies may suffer from just simple anemia, and this anemia could be severe up to the occurrence of whether heart failure and ascites and pleural effusion and skin edema and scalp edema is, as we said before, is part of a hydrops fetalis. How could you diagnose the condition? All pregnant women should be tested at the time of the first prenatal visit for ABO blood group and RHD type, and screened for the presence of erythrocyte antibodies. These laboratory assessments should be repeated in each subsequent pregnancy. Antibody screening is also recommended before administration of anti-D immunoglobulin at 28 weeks of gestation, postpartum, and the time of any event in pregnancy. Any antibodies potentially associated with fetal hemolysis found during this routine screening are further evaluated based on the strength of the antibody response, which is reported in a titer format, 1 to 4 or 1 to 8 or 1 to 16, etc., or simply as just 4, 8, or 16, with high numbers indicative of a more significant antibody response. This is measured by a test which is called indirect COOMB'S. Assessment of Rh immunized lady should pass through various steps. So how will we start the assessment? The assessment should be started just simply by measurement of the antibody titer. As we said, by the indirect COOMB, we're just going to speak about it in a couple of minutes. Although the antibody titer reflects the strength and the amount of the maternal antibody response, its utility in pregnancy management is limited. titers provide little information about the fetal status. A critical titer is that titer associated with the significant risk of severe fetal hemolytic disease and hydrops fetalis. In most centers, this is between 1/8 or 1 to 8 and 1 to 32. If the initial antibody titer is 1 to 8 or less, the RHD negative patient can be monitored with titer assessment every 4 weeks. In a first sensitized pregnancy, titers are generally performed every 4 weeks. With a history of an unaffected fetus or infant, titers are not helpful. With a history of a previously affected fetus or an infant, titers are not helpful in predicting fetal hemolytic disease, and further evaluation is needed. Take a look at this figure and tell me what you understand from it, and we will discuss this in the face-to-face session. This is the indirect COOMB, as we said previously. Amniotic fluid assessment is an assessment of the level of the bilirubin that has been usually used as a tradition to measure the fetal status and an indirect means of estimating the potential for severe fetal anemia. In the second half of a normal pregnancy, the level of bilirubin in the amniotic fluid decreases progressively, whereas in an affected isoimmunized patient, the amount of bilirubin detected can deviate significantly. The increase in the amniotic fluid bilirubin in affected pregnancies is thought to be a result of fetal urinary excretion of the increased amount of circulating bilirubin. Until recently, serial amniocentesis were performed to determine the level of bilirubin in the amniotic fluid, which in turn reflected the severity of the anemia. Actually, the chart that we used to use, it's called Lilly's chart. What did we do? We just took amniocentesis, and we took amniotic fluid sample, and we measured the bilirubin level by optical density difference between the normal and the abnormal levels, and we plotted it on a graph or a chart, which was called Lilly chart. And according to the severity of the affection of the baby, the patient was put on the chart as highly affected, moderately affected, or not affected. And this is a bit invasive test that we stopped using it nowadays. The next step is ultrasound assessment. So we spoke at first, the first step is the antibody titer, and then we spoke about the amniotic fluid assessment, and then now we're speaking about the ultrasound assessment. This is actually the current trend in the management of measurement of isoimmunized patients. The peak velocity of the middle cerebral artery flow using a Doppler ultrasound. This is the current trend in how do we follow up isoimmunized patients. The velocity of flow through the middle cerebral artery is related to the viscosity of the blood. In the setting of fetal anemia, the blood is less viscous due to fewer cells, and therefore the velocity of flow increases. The degree of peak velocity elevation above the median for that gestational age can be used to estimate the fetal hematocrit and thus the risk of fetal anemia. Using the peak systolic velocity of the middle cerebral artery, almost all fetuses with moderate to severe anemia can be identified. The calculation of the multiple of the median is important in the assessment of the degree of the anemia. This is a picture of how we measure the peak systolic velocity of the middle cerebral artery, and we calculate the multiple of the median from it, and we put it on graphs, specific graphs, and we identify if this patient is anemic or not. This is the multiple of the median graph, where we see the picture with triangles above more than 1.5 multiple of the median, and these babies are affected with anemia and isoimmunized patients. Ultrasound assessment of the fetus is also helpful in detecting severe signs of hemolysis that have resulted in profound fetal anemia. Occasionally, the first presenting signs of fetal hemolysis may be hydropic changes in the fetus, including subcutaneous edema, pericardial and pleural effusion, and ascites. And unfortunately, these may be a bit late. When these findings are identified and hydrops fetalis is diagnosed, the fetal hematocrit is typically less than 15%. So it's much better to early diagnose the condition by following up the RH titer and early detection of early signs of anemia using the peak systolic velocity of the middle cerebral artery. The monitoring tests indicate a risk of fetal anemia, or if hydrops is diagnosed. Chordocentesis, or percutaneous umbilical blood sampling, is performed to directly measure the fetal hematocrit. Under ultrasound guidance, a needle is advanced into the umbilical vein, a sample of fetal blood is removed, and the hematocrit is measured. In general, the average fetal hematocrit is up to 44%, and with severe anemia is less than 30%. This is a graph or a figure in order to tell you how we follow up the patients who are isoimmunized, starting from the titer, from the history taking. You could take paternal antigen testing or possible fetal DNA testing, assessment of risk of fetal anemia, amniotic fluid bilirubin assessment, serial antibody titers, middle cerebral artery Doppler, and ultrasound. So, how could you prevent the condition? The management of any condition is divided into primary, secondary, and tertiary prevention. Maternal exposure and subsequent sensitization to fetal blood usually occurs at delivery, but it can occur at any time during pregnancy. In the late 1960s, it was discovered that an antibody to the D antigen of the Rh system could be prepared from donors previously sensitized to the antigen. Administration of the anti-D immunoglobulin soon after delivery prevents an active antibody response to the D antigen by the mother in most cases. Anti-D immunoglobulin is effective only for the D antigen. Put this in mind. So we have other antigens that giving the anti-D immunoglobulin would not serve protecting the patients from. It's not effective in preventing sensitization from other antigens. A prophylactic dose of 300 microgram should be administered. Each dose of anti-D immunoglobulin provides protection against sensitization of up to 30 milliliters of fetal blood or 15 milliliters of fetal red blood cells. In case of trauma or bleeding during pregnancy in which there is a potential for more than 30 milliliter fetal maternal transfusion, the extent of the fetal maternal hemorrhage can be assessed using the CLEA or Becky test. This test identifies fetal erythrocytes in the maternal circulation. The number of fetal cells or the proportion of the total cells can be determined, and the volume of fetal maternal hemorrhage can be estimated. An indirect COOMB test can be used to determine if the patient has received sufficient antibody. A positive test is indicative that the patient has received an adequate dose, because even a minute amount of fetal red blood cells can result in sensitization, which is up to 0.1 milliliter, which is very little. In any circumstance, when a fetal maternal hemorrhage can occur, the anti-D must be given. This is the anti-D injection. Since the introduction of the prophylactic anti-D immunoglobulin given to all unsensitized Rhd negative women after termination of pregnancy or delivery, there has been a dramatic decrease in the rate of Rh isoimmunization. In the United Kingdom, for example, prophylactic anti-D immunoglobulin has been used since 1971. The stillbirth or neonatal death rate due to Rhd isoimmunization reduced from 120 per 100,000 births in 1971 to 1.3 per 100,000 births in 1992. Still, there are around 600 to 700 new cases of Rhd isoimmunization happening every year in the UK. The reason suggested is either due to insufficient dose or failure to cover a potentially sensitizing event. So now, you diagnose the patient as having fetal anemia, the hematocrit is less than 30%, and you need to do an action. What's the action that's going to be taken? The action is actually fetal transfusion of packed RBCs. Previously, the blood was transfused into the fetal abdominal cavity, where absorption of the red blood cells could take place over several days through the lymphatic channels. Currently, the transfusion of antigen-negative red blood cells, depending on the blood group involved to the fetus, is indicated when the blood sample from the umbilical vein determines that the fetus has a moderate or severe anemia with a hematocrit less than 30%. Direct transfusion under ultrasound guidance into the umbilical vein has become the preferred technique. This is a diagram of the procedure which I just spoke to you about, where 3 personnel must at least be present, one holding the ultrasound and the other doing the procedure and the other taking the samples for calculation of the hemoglobin and preparing the samples for their transfusion. We put a needle inside the umbilical vein, ultrasound guided, and we transfuse a specific amount which is calculated by a specific equation in order to replenish the anemia that's present inside the baby. This procedure is repeated after 2 weeks, and then it's repeated every 3 weeks until you either reach to 35 or 30 weeks, or you find that the baby is doing fine by following up with the middle cerebral artery peak systolic below. The procedure has a 1 to 3% risk of complications, including fetal death and preterm delivery, which must be weighed against the predictive course of the fetus if left untreated or delivered. The volume of red blood cells to be transfused can be calculated based on the gestational age, estimated fetal weight, the hematocrit of the unit of blood, and the difference between the current fetal hematocrit and the desired hematocrit. The blood that should be transfused should be O negative, packed red blood cells to a hematocrit of 75 to 80%, fresh to the level of 2,3-diphosphoglycerate, leukodepleted to decrease the risk of graft versus host disease, cross-matched with the maternal serum, and of course, the blood should be properly prepared with hepatitis B and hepatitis C and HIV negative. So, how could you assess the degree of the feto-maternal hemorrhage? Various tests are used. We spoke about the CLEA or Becky test, which we add acid to hemolysis of the maternal red blood cells, causing ghost cells and no effect on the fetal red blood cells, which remain pink. Flow cytometry, which we prepare monoclonal antibodies to the hemoglobin F, and APT or alkali denaturation test. This is the picture of the Kell-Antigen test where we see the pink cells. These are the fetal cells present beside the ghost cells. What is the management of a sensitized pregnancy or a delivered baby? First of all, we should assess the baby properly, and we should assess the amount of hemolysis or the amount of the anemia, and we should also assess the degree of hyperbilirubinemia present. There must be cord blood for blood grouping and bilirubin and direct COOMB'S test. We should do a phototherapy for the cases of jaundice, and if the condition is severe, we could give exchange transfusion to the baby, where we give donor blood and take away the blood that is full with the antibodies that could cause further hemolysis. So we could replace the neonatal blood, now he's neonate after the delivery. We could replace the neonatal blood by exchange transfusion. So this is about the antigen. Is it only about the antigen? Although the routine use of the Rh immunoglobulin has decreased the isoimmunization due to the D antigen, isoimmunization due to other blood group antigens has proportionately increased. The frequency of these antibodies varies depending on the frequency of the antigen in the general population and in various ethnic groups. Another very important antigen is the Kell Antigen, which is an antibody screen could detect the presence of this antibody. The most important cause of hemolytic disease of the fetus is not associated with the D antigen of course, in developed countries, but is isoimmunization with the Kell antigen. This sensitization commonly results from a prior blood transfusion. If a maternal antibody screen reveals the presence of anti-Kell antibody, you should do a paternal blood typing for the Kell antigen to make sure that the fetus may have the possibility of the Kell antigen. Anemia resulting from Kell isoimmunization is unique in that the predominant effect of the antibody is destruction and suppression of the hematopoietic precursor cells. Hemolysis is only a minimal component of the fetal problem. For this reason, amniotic fluid surveillance of the bilirubin may not be as useful in monitoring these pregnancies. And middle cerebral artery Doppler, which is the current trend, as we said, is preferred surveillance method. Most providers use a critical titer measurement of just 1 to 8. Not 1 to 16, as we said in the anti-D isoimmunization, to initiate further evaluation in Kell-sensitized pregnancy. This condition, which is ABO Hemolytic Disease, is mainly in the neonatal state, where the maternal fetal transmission of red blood cells leads to the destruction of RBCs inside the neonate with a bilirubin load on the baby that exceeds the liver capability, leading to occurrence of hyperbilirubinemia and jaundice. The ABO Hemolytic Disease is due to maternal fetal incompatibility. It's usually associated with mild fetal and newborn hyperbilirubinemia. Typically, it's not associated with severe fetal disease because there are fewer A and B antigenic sites on the fetal red blood cells than on adult blood cells. In addition, most of the anti-A and anti-B antibody produce the IgM isoform, and these do not cross the placenta. So, this is the immune hydrops because of an immunological cause. So, is there something called non-immune hydrops? Yes, of course. And this forms more than 90% of the cases. What are the causes of non-immune hydrops? What do you mean by non-immune hydrops? That we could not identify a specific antigen-antibody reaction. The causes may be cardiac conditions like ventricular septal defect, transposition of the great arteries, Pishtian anomaly, which represent 40% of cases, fetal hyperthyroidism or tachyarrhythmias, alpha thalassemia, parvovirus B19 infection or Storch infections, recipient twins of the twin-to-twin transfusion syndrome or twin reverse arterial perfusion syndrome, Down, Turner, Noonan syndromes, congenital pulmonary malformation, sacrococcygeal teratoma or placental angioma. Lots and lots and lots of causes could cause fetal hydrops. And when you start looking for the cause, you could not find any antigen-antibody reaction. And then it's called non-immune hydrops fetalis. This is a picture of a huge sacrococcygeal teratoma leading to hydrops fetalis of the baby. So this is clearly a case of non-immune fetal hydrops. This is a diagram, a flow chart, an algorithm for the management of cases of Rh immunized patients, and we're going to discuss it in details in the face-to-face presentation. Please be ready with your questions in the next presentation. Thank you all for your time.